evening. The evening is now 6 o'clock. Now call this meeting of the Scott County Board of Health to order. We please say our invocation by Dr. Hughes.
Let us pray. Father God, thank you for this time that we can spend together serving our community. Help us to set aside other agendas, to have open hearts and open ears for your guidance in these decisions we are making on behalf of our fellow citizens. And also thank you for this season that we are in and for the reason of it. In Christ's name I pray. Amen.
Amen. Thank you. We will now have our oath administered to our new board member, Mr. Edward O'Neill Jr., who is our new county commissioner representative. Over here. Microphone.
Okay, repeat after me. I, Edward O'Neill Jr.,
I, Edward O'Neill Jr.,
do solemnly swear
do solemnly swear
that I will support and maintain the Constitution and laws of the United States
that I will support and maintain the Constitution and the laws of the United States
and the Constitution and laws of North Carolina,
and the Constitution and laws of North Carolina,
not inconsistent therewith,
not inconsistent therewith,
and that I will faithfully discharge the duties of my office
that I will faithfully discharge the duties of my office
as a member of the Scotland County Board of Health, so help me God.
as a member of the Scotland County Board of Health, so help me God.
I do further swear
I do further swear
that I will well and truly execute
that I will and truly execute
the duties of the office as a member of the Scotland County Board of Health
the duties of the office as a member of the Scotland County Board of Health
according to the best of my skills and ability,
according to the best of my skills and ability,
according to law,
according to law,
so help me God.
so help me God.
Thank you.
Thank you. We welcome you, Commissioner O'Neill, to our board, where we work for people of Scotland County. And everyone should have received their packets in the mail. So if there's any discussion for the agenda, because please note it now.
No comment.
All right. Seeing as we have no discussion on our agenda, we'll now have a motion to approve our agenda as was provided.
Second.
It will be moved by Diane and second. For all those in agreement, say aye. Opposed, same. Motion is carried. We'll continue with our agenda as provided. We will now be open for our public forum. Is there anyone present in our public forum? All right. Seeing as there is no one present in our public forum, we will continue to move on with our agenda as provided. And we will have our fiscal management update by Mr. Tim Martin. A new fiscal management plan should have been provided to you at your seat to update the one that was in your packet.
Good evening.
I have to.
Good evening. This is the
is the financial update as of November 30th, 2024. The first slide that you will actually see in your packet is we are required by our wonderful accreditation that once a year at least, when I do a financial report, that everything, financial decisions we talk about or things we discuss have to deal with the 10 essential services of public health. That's an accreditation requirement. So I'm sure you all are familiar with those 10 essential health services, public health services, but I have to say that during the financial presentation. So I'll give you just a minute to look over the next slide. Once again, the reason these slides are not in your packet when they're sent out usually is by the time the county does the end of the month stuff, the packets are already sent out. So that's why I'm unable to send them out ahead of time. So the first sheet that you have is the expenditures for the health department. 5 months, which should be 42% expended. And the last column, you'll see is the total of the health department, we are at 34.3%. So we are currently still under budget from where we should be at this time of year. Once again, I will draw your attention now to the immunization line, which we'll talk about later on tonight. You'll see that it is overexpended as because we are purchasing more and more private vaccines. But if you'll see on the next sheet, you'll see that our revenue has increased in that area. So that's because we are buying more vaccine, but we're giving more vaccine and making more money. Does that make that good? So any questions on this first sheet for expenditures?
Is that number reflected just because of the season that we're in? We tend to immunize a lot more this time of year. So like we'll stagnate come May, June.
Exactly.
And I also think we get more back-to-school vaccines this year.
Yeah, we've done a lot. I think we've done a little more vaccines this year than we have in the past, but you are correct. This time of year, it expands because we're giving out flu shots. We just started back giving updated COVID shots. So when I say private vaccines, those are people who have third-party insurances. And Medicare is considered a third-party insurance. So anything that's not Medicaid or just not Medicaid is considered third-party insurance. So a lot of seniors will come to the health department to get their shots, but if they don't want to go anywhere else, they feel more comfortable coming to the health department. They've been coming to the health department for 20 years, and they come and get their flu shot here and they're getting their COVID shots. So that is third party. So that's private insurance that we have to actually purchase the vaccine ahead of time, and then as you see later on tonight, we cost it out. So we actually make some sort of profit to help with the cost of providing the service.
Would you explain real quick just the fiscal year? Is it a June to June fiscal year?
The fiscal year runs from July 1 to June 30th. That is the county's fiscal year. I will say the state of North Carolina's fiscal year, however, especially our AAs or our grants we get from the state, actually run from June 1 to May 31st. So there's about a month in there where we are off with the county as far as grants and stuff. So we usually make that up in the next one.
And our WIC office runs off of a federal fiscal year, which starts October 1st.
Right. That's what was a little confused. Thank you.
Any questions on that? Okay. The next slide, it will be the revenue collections. As you can see, it's also 42% collected. We are at 27.2% collected. If you look in the federal and state line, please note that the federal and state line is always a month behind. Services we provide in November do not get reimbursed until December. So therefore, that will show up next. So we're a month behind usually in that column all the time. As you can see down in immunizations, you'll see that we're over our revenue budget in there because of those immunizations. And also you see adult health, where we did a lot of school physicals this year, way more than what we've done in the past. School physicals or work physicals that we have done in the past.
So that's.
adult health.
And where would, where would the revenue from, like, our partnership with St. Andrews, or that, like, grant, so it doesn't come?
That's the women's health line, that 5048 women's health SAE.
Okay. That's only been up, how many months now?
October was our first.
They didn't start providing services.
So if adult health is our school physicals, so our kids' school physicals are not included in childhood, what's in our childhood?
The school physicals and adult physicals are adult only.
That's what I.
We don't do children.
Oh, the one for the college. Oh, okay. So we have
They
a college-
basically come in with a paper from their college or wherever and say, this is what I need, and
And then we do it,
and we
we
do
get a
it.
call from the shops if they need it.
Yes, correct.
Okay. So we went up on those.
Yes, ma'am.
Okay.
Can it be a work readiness physical, like for a CBL or something like that?
We have talked about that in the past, trying to do CDL or DOT physicals, work physicals, but I think every time we've talked about it, it's, I know we've talked about it before, I'm looking at Donna because I know we've talked about it before, but I don't know what the procedures are for medical.
We haven't talked about it since I've been here.
Yeah, I talked about it with Elisa, and she says that a lot of your CDL, physicals require a certain type eye exam, and we don't have that equipment.
I know there's a lot of people trying to go back to work and taking courses like CDL and stuff like that. And there's assistance for the training, so I didn't know if the assistance for the physical would also be worthwhile.
So, I mean,
I'll make-
do we
I'll make-
have, like, because we have other funding or different things, you know, we have like grant and other money that we do have to like try to spend, how much is it that we would have to like employ, like, ophthalmologists to use that equipment, or is it just using like I know our clinic, we use a spot vision, which can still gives you everything, you can know if you have gaze, astigmatism, it tells you whether it's myopia, if you have unequal power vision, a very in-depth, like, screening. Because if all you would need is to purchase like that spot vision, then we could purchase a spot vision and then offer to do those for CDL.
We have one.
We do have one? So that's,
Could we maybe check and just verify?
yeah, so she,
We used it for child health.
Yeah, we have child health, and then we have
We purchased.
okay.
And the one with the flashing light and the bird.
Yeah.
So I'll make note of that. Any other questions?
Can you talk a little bit more about the women's health grant at St. Andrews? I'm just not familiar, so.
I'll let Ms. Amanda talk about that.
So I applied for a grant from the state, and it's called Support Women's Health. And it is kind of confusing because it says women's health, but we can also see men as well through that, and it's an extension of family planning. So we can provide family planning service either in a lake clinic or outside at a satellite clinic. So we partnered with St. Andrews to pick up the college population for family planning. So we go there on Wednesday afternoons right now, and it was rolled out in October. But we get, I think it's $150,000 a year for 4 years. Is it 4 for at least 3 years, we'll get $150,000 a year to provide that service.
Thank you.
And because in December, a lot of the college kids were leaving to go home for a winter break, we did offer a evening clinic with extended hours the second Wednesday, I think it was, in December. We didn't have a lot of participation from the community with that, when it was advertised, but we did offer it. All that's part of that group. And when I say the guys can be screened for STD and provided, condoms and counseling on family planning.
Any other questions, financial wise, or? Okay. Thank you so much for your time.
Once on that, everyone should also receive the minutes for the October 15th meeting. Know that any corrections or additions to the October meeting?
Talking about on page 2, it says at the bottom of the last thing, it says Dr. Bowling asked what this process would look like in the future. I don't remember who that was. I can't remember. I know it was Dr. Bowling, but I don't remember. But that is Dr. Bowling is the area. It might have been, I don't remember that's the question down here.
Oh, yeah, it was not Dr. Boyd.
It was me.
It was Dr. Hughes.
Yeah.
So on page 2, the last bullet point, it should not say Dr. Bolden asked what this process would look like. It should say Dr. Hughes asked what this process would look like. That is from our closed session.
Can I ask a question? On page 2, Valentina Oxendine stated that we're currently working with the animal shelter on the intake process for cats and dogs. Do you know when an update will be received on that process?
I
think
don't know
that's
exactly
previous.
what that said.
I think it's previous meeting minutes.
Oh,
That's pretty good.
yeah, that's something that was done in our previous meeting. So, at the start of last year, we, were having some issues with animals and not being appropriately able to shelter them in our humane shelter, for they told us there was no space. And so we had lots of animals that were still loose, and people had complaints, and so we got contact, Amanda met with our county manager. They, reviewed that contract with our Humane Society, and they all came to the table and constructed a new contract, because we were still paying money for services that were not rendered. And so we had them renegotiate that contract so that we are not paying them for services not rendered to the county.
This read like there was some work in progress or something, so.
It's
that's
still-
what was-
So there's still, it's still an ongoing relationship that has to continue to be built and fine-tune things worked out.
So we get another update perhaps
Just like time you're on the agenda here soon, you want to speak to that?
in February maybe or something?
I can. We've been going back and forth and getting the emails. We used to get a weekly, but it has become better. We're able to kind of our animal control officers call ahead of time and see whether or not they're able to bring a dog in, and they'll work with them to place them until they can possibly screen them and have a rescue to come pick them up, or like this a euthanized shelter, so they'll euthanize. So we've been getting updates from the director there that says we have so many kennels available. You can bring such and such amount of dogs, bring such and such amount of cats. And we've just been working with them. That's all we can do. Or we will tell the public, we'll have to wait a couple of days until we get some money. And normally they've been pretty understanding since it's been an ongoing process.
So, I get a motion to approve the minutes with a one noted change.
Motion to approve.
Second. All those in favor of approving the minutes with the one noted change, say aye.
Aye.
Those opposed, same. Hearing none, we will accept the minutes with that one noted change in the closed session in the minutes. All right, we will move on to our clinical updates with Ms. Donna Page.
there, Clifford. Okay. Good evening, I'm Donna Page, Director of Nursing, and in my clinical update, this time I'll be doing the end of year CD report on 2023 data. And this is an accreditation requirement with activity 2.4. So there'll be opportunities to ask questions at the end, but if you have a burning desire, jump in there. So here I go. So first we'll talk about sexually transmitted disease. Now this is in just Scott County, but I'll do some comparisons with code with state rates as well. So, and you should have in your packet smaller slides of this. And so the majority of our STDs are chlamydia and gonorrhea. And we, even though we border Robinson County, we don't have nearly as much syphilis as they do. But we did have a total of 601 reported STD cases in 2023. So with chlamydia and gonorrhea, chlamydia being 66% of that, gonorrhea is 30%. So those are always our top two STDs. And by age distribution, you're looking at ages 15 to 24 is most of the cases. And gender, more female than male. Race, it's black or African American, is white and American Indian. By Hispanic, we don't have a huge Hispanic population in Scott County, but there were 5. So our rates compared to Scotland County to the state, our chlamydia rate, as you can see, is about twice that of the state rate. Gonorrhea, not too far off from that, it's about twice that as well. Our syphilis rates, again, primary, secondary, early, are lower than our state rate, than the state rates. And, syphilis has been around a long time, and there's only one best way to treat it, and it's crazy. It's just an old disease that, it seems like there's no way to eradicate it like it has so many other things. But always, just like TB. Our STD trends, and I'm getting a little bit of calculations that I didn't add on here. So with our chlamydia from 2020 to 2023, our rates went up about 26%, in 2020, gonorrhea 15%. Primary and secondary syphilis, while our rates are low, our rates went up 147% from 2020. So, and then early syphilis was 14%. And for those of you who don't know the difference in the two, primary and secondary syphilis typically have symptoms. Early syphilis is usually in the first 12 months of infection where they don't really have any symptoms. But primary and secondary stages do have different symptoms like lesions and rash and those kind of things. So there's a little, they treat them a little bit differently too. Bicillin is the treatment of choice, and they'll either get one dose or they'll get one dose every week for 3 weeks to treatment. And so I work with our state disease investigation specialists who actually monitors our syphilis and our HIV. They're the ones who reach out to new syphilis cases, new HIV cases, and we work closely with those, our regional offices in Fayetteville. So we talk to those folks a lot, and when our county residents have HIV or syphilis, we make sure they get seen, get treated, get care, and so that's our role. Now, chlamydia, gonorrhea, other communicable diseases, me as the communicable disease nurse is the one who calls the people with the communicable diseases and the STDs to make sure they get treated.
Question. So the number of like positive is it from people who were tested in our county and found to be positive, or those whose address the
Address in Scott
of this county? So therefore, they can come to our health department, but if they live somewhere else, that number is counted from where
For
they
that
live.
county, yes. So we have
So
Robinson
even if
County.
they live here, but they go to Hope County or Cumberland County to get tested, They're still counted in our,
Yeah, it's reported. So hospitals, doctors' offices are well educated in reporting disease. So, you know, if there's, because we see people in Robinson County, so when we have a Robinson County resident or a Hope County resident, that case goes back to them. We work in a system called the North Carolina Electronic Disease Surveillance System. We call it NCEDS. Eventually, we just call it EDS, because it gets to be a mouthful. But every case for Scotland County reports into NCEDS. And there's also NC COVID. And when COVID was a reportable disease, so we were working in two different systems. At first, it started out all just NCEDS. Then COVID overloaded it, and they had to create its own complete separate system for COVID. So, yeah, everything that comes in, and we often see it before the doctor's offices. Many times, I'll call the doctor's office to ask, have you seen it, especially like with pregnant women or higher risk populations. I'll go ahead and call and say, have you called this patient, have they been treated? But some of them don't report like they should to the health department. They're supposed to send us a report form. And they don't even know it yet. So it's interesting. Yeah, that's what I'm here for. And sometimes it's a little hard because you have somebody in another state. And then eventually the interstate notification goes through, and it might take a month to get back to me. By the time our first COVID case was in Johns Hopkins, that was our very first county case. So that was not even in our county, but it was our county resident. HIV, our rates pretty much for HIV have more or less remained consistent on average, anywhere from 9 to the most we had was in 2022 with 13 cases. Now, because we're a small county, we have a very small population of what is it now, 30-some thousand, 34,000 used to be. It's per 100,000. We always, because of our small numbers per 100,000, we usually end up in the top 10 new HIV cases in the state. This year we were the third. No, we went down to the fifth. Last year we were the third. So when you look at 30, 40,000 people, and you got 13 new HIV cases, and that's why we got the PrEP clinic started trying to do some prevention before they became HIV positive. But we hope that the rates continue to, and I think this year we're over 9 already. I think we're going to be more towards the 10 and 13 when the year is over. And actually, there were 10 reported in NCEDS, but one of them was a South Carolina resident. So if you look at the numbers on our annual reports that the state puts out, and I've asked them to correct this, but they did not. So now on our annual report, it's showing we had 10 cases in 2023, and we only had 9. And because I know every case that goes through, and there were only 9. One of them was South Carolina. I asked them to remove that one from our cases, and it's still showing it. So we don't have 9. If you ever go there and look on the Communicable Disease website, they have annual reports, quarterly reports, and all sorts of things right there. So, and the data that I do actually comes from reports I run, which are really close to state numbers, but the state system can be a little jinky every now and again, and if a person moves, that case, it just does weird things. So I know who has been reported, and these are the numbers that I give you guys. I think it's a truer picture, actually, from what the state does. My distribution, our HIV is a little spread out, more spread out this year than it has been. But we are seeing most of the cases between 25 and 39. Most of the people who are living with HIV are older now. They're 60, you don't see any new cases in the 60s. You're seeing them like 15 to 19. The younger people, you're seeing it in younger populations. But there's a lot of people who, back when I worked at UMS in the 80s, before they really knew what HIV was, I see people with AIDS die with AIDS. But there's a lot of people who are still living very healthy lives now because of the advances that have been made in HIV medications, and 1 pill a day, 1 shot every other month. I mean, people live healthy, wonderful, productive lives. And I thank God that that has, I don't ever want to see what I lived through back in the 80s. Gender-wise, we have 6 males, 3 females, 2 more males, 7 females. HIV demographics by race, again, the black population. And I will go ahead and some of the black males are usually the ones with HIV. But it's not all consuming, but that's the prevalence. And I've sort of discussed the other things, that STDs are higher in females. And I'll say something about the female STD rates. Females are the ones who go to the doctor the most. They're the ones who get the pap smears. Males will not show many symptoms, especially with chlamydia, which is our highest reported disease. And it's usually the females who figure it out. Now, if it's gonorrhea, males are going to know they have gonorrhea through fluids. But not with chlamydia. So it's most prevalent because of it's asymptomatic in males and females. So females are the ones who go to the doctor, they get tested, and that's why you see it in females versus males. Moving on to communicable disease. We had a total of 59 in 2023, with Hep C, chronic Hep C, being at the top of that. There's an explanation for that. When you see 71% of our reported communicable diseases are Hep C, we have a prison in our county. And these Hep C cases come from the prison reports. When we have inmates in the prison, they become our residents. So that's where that comes from. So if we didn't have a prison here, we might have 3 cases. Okay. That's pretty much, CRE happens in rest homes. That's usually happens in the elderly population. Salmonella and Shigella, those are foodborne, which typically is in early, they're very young. I think 2 of those are children. And the other ones are elderly. Those would be very young and very old. And there's the age ranges. There's 3 from 1 to 4. And might have been all 3 of those food ones. And then we look it down, it's kind of spread out to 30 to 60 really with that. And I think that probably covers the prison population quite well, those age ranges. And then look at male, 78% of those cases are male. It's a male prison. I'm not saying that's all of them, but almost 13 were female. And then by race, you got 56% of these are white. So this is one demographic where it exceeds the other demographics. And little known fact maybe to some, but I through just going to different. And I did some research on it. It's really hard to figure this out, but because white people are more, white males especially, are more prone to IV drug use than black males, or white population. They tend to do more of that. In our region anyway, now when I look at the statistics nationwide and worldwide, it pans out a little bit different, but in our region, for some reason, this is how it falls. Hispanic and having Hispanics in that. And that's pretty much it for the annual report for 2023. I used to do this in November when we met monthly, and next year we're going to try to do it in October instead of December. So it won't be so much into the holiday season. Any questions?
You talked about the growth of STDs over that 4-year period. Are there specific tactics or countermeasures you guys are doing to kind of have an impact on that?
I would say that as far as prevention for CD, we do a lot of education every time, especially if you see people come in and if it's one case, it's one case. So one person might get chlamydia 3 times, it gets counted 3 times. But we do our best to educate and prevent, which is what public health is supposed to do. I think when it was with syphilis, which again is not that great in but HIV is also something I've had some concerns about. A lot of the people get tested in urgent cares and emergency rooms. So it's amazing how many, I would say 70% of our cases are tested, at least 70% are tested in emergency rooms and ERs. When they go in to get chlamydia gonorrhea, they do not get syphilis and HIV in the emergency rooms. I left a message for Mr. Pope at the hospital several months ago because I really wanted to reach out and find out what the barriers were to people being tested for HIV and syphilis in ERs. Because they always, I read the notes, I have access to their EMRs, and they always say at the end of the visit, they tell the patient to go be tested for HIV and syphilis at the health department. Well, they're never gonna come. They got what they wanted, they're on the spot. HIV needs to be more normalized into our care, our preventative care, even syphilis. But HIV, to reduce the stigma that HIV carries, if every physician's office just started saying, hey, we're going to do your CBC, we're going to check your blood sugar, and let's do some HIV test, a syphilis test, if they could normalize those things. But again, until they can figure out and it's not just our emergency rooms, across the board emergency rooms. I don't know, because there are rapid tests they can do, which are not as reliable as the send-outs. But sometimes, every now and then, they'll do a rapid. But I think that they're doing it, treating it symptomatically, and when they don't see a need, that's something that they don't feel like they should spend money to do, or insurance is not, I'm not sure what the barrier is, and I haven't been able to get an
I
answer.
know in the VA, it's optional now. After the big pump with HIV/AIDS, all of a sudden the VA said, you can have it done annually if you want to. So maybe that attitude is sort of carried over with others.
There's, and I have to go, part of being a city nurse, I have to go to an annual update. And it's not just us that has this issue, it's counties across the state that, I've asked questions at those conferences about how can we impact that testing and and they know we're there. They know they have to report these results to us, so, but again, they get what they want in the emergency room and they go home. And I don't think they get the education that we would give them if they came to us. So I think that a lot of it's education and outreach and sharing information. I had a parent call me today, and her daughter's in college, and her daughter she wants me to talk to her daughter because she was positive, and she's just, young women need to understand how to protect themselves. Men do too, but it was obvious when she was asking me to talk to her mother, and then her mother wants me to talk to her, and that she probably has, she's a little shy, and she needs to learn how to be empowered to take care of herself.
And so I think that is why I think even in our strategic plan, that's why we want to focus on destigmatizing what the community preference is of the health department, because from what we know from these last couple of years, that the community does not have the best view of the health department, and also the stigma of coming to the health department to get vaccines and do different things. And so we are working on, as part of our thing as the board, what we were work on is increasing our visibility in the community as a helper and a support, so that people are comfortable coming in to get the help they need without having that stigma or those thoughts that they have in their head, because that's something that I also get in clinic. And I have to send my patients to the ER or to the hospital to get their STD and tests and things done. And I'm a pediatrician. So to know that as a pediatrician, I have to send these tests out to let you know that we're doing this on kids that they would have to ask their parents to bring them to the health department. So sometimes we're gonna have to go to them or find a way for them to get tested, because I've had teens who tested positive and still look at me in my face and say, I don't have an STD. And I say, but you do, which is why I'm giving you this Rocephin shot and this prescription. And so we have to educate them. And also, the same thing like with the lady who called you for help, is let them know that they have a safeguard and somewhere they can go to get the treatment. Because I also had a teenager in my clinic who we got his positive result back, and it took him a year to come back to our clinic to get treated. And it's because his parents couldn't find him. We called his parents couldn't find him. And so, but they found him when he scheduled his appointment with us. He came back for his yearly. And when he came back, that's when I finally got to treat him, but who knows who he spread it to. And so that's why these numbers I know are probably significantly lower than our true representation of numbers,
Definitely.
because I know the numbers that I see. And we want to make it where they can come, which is something I was going to have in our new business, having some new things to work towards as a board, like focusing on like the STD things here, and how can we help empower our community to be healthier and make wiser decisions, because that's really where it comes from, is making that decision before you in that for good. And hopefully I can help you go talk with them, because also the thing is, the syphilis and the HIV tests are blood tests, where you can test gonorrhea and chlamydia in urine. So whenever I do send my patients, I can have them go to the bathroom in my clinic and send it, and I can fold up that order sheet and put it in the urine, and the parents don't have to know that I'm sending a gonorrhea and chlamydia for your child, so the parent still doesn't know the child is sexually active. But if I have to give them a blood test order, and they're going to get blood drawn, the parents are like, why are you getting that done? You know, and so sometimes in the ER, that's another thing. It's much easier because they're already going to the bathroom to test for gonorrhea and chlamydia, where we're gonna have to do a venous draw.
Yeah, I've read records where the
So,
teenager goes into the emergency room because they have a sore throat, and they get tested for gonorrhea.
yes,
Instead they're positive, so you know, I know that happens.
yes, and that's how it happens.
Can I ask one question about this? So, I know it's sexually transmitted disease. Is there a reason that herpes is listed there?
It's not reportable.
It's not reportable.
There's a list of reportable diseases that herpes is not one of them. Now, when we have people who have herpes, we call them with educate on that, what that is. It's not reportable.
What do you attribute the increase to from 2019 to 2020?
Well, I felt like during COVID, I know this, during the craziness that was COVID, people didn't go to doctors as much as they were going. I felt like we were on the back end of COVID, we were gonna see things like this happen. Just because now, I don't know why it continues to rise after 2022, but, we are just looking at 2023 up to that. So maybe this year will level out, maybe next year's report is coming down a little bit, but I do believe that a lot of people just did things that kept them busy while they were on quarantine, and didn't go to the doctor to get tested, and now it's all sort of rolling out. And I would say last month, we only had 33. When I did the activity numbers, which was crazy. I went back and checked, and I was like, this cannot be right. We never had just 33. So I thought that was interesting.
I think COVID will always be a benchmark for a number of things. We'll always go back to that before COVID and after.
Absolutely.
We're all sorts of stuff.
Thank you very much.
We will now have our health director's report. Oh, it's on there, everything, you've gone with that.
Almost got it. Good evening. I'm Valentina with Environmental Health. Just a couple updates. We finished out strong with 2024 with our events. I would say that we, between my coworker and I, was hardly it. We covered about 15, 20 events this year. That was permitting of food vendors, not counting events held by churches to where we didn't have to do permitting. We just offered education. So now we're at the end of the year, we've been focusing on our state compliance requirements, which is our inspections for our food and lodging establishments, and evaluations is coming in as far as our soil evaluations and our well evaluations. Since our last Board of Health meeting, just a couple of updates, we have opened up 3 new restaurants, which is Tiquiera El Ranconcito, which is a Hispanic restaurant in the Old Roses Group. We have opened up Fat Rabbits, which is in the north side of Food Line North, and then Adrian's Restaurant, which is in the Old Pizza Hut. Closings, Golden Corral has closed down. Harley's Soul Food, which is on McCall Road, and then Trade's Blazing Hoagies, which is in that little strip there between Scotland County and Robinson County and Madison. We have 3 plan reviews that we're currently working on, which is Stop and Go Store. There's a little grill that will be opening up there. The Bird 401, which is in the old Little House, and then Asahi that will be closing now. We've closed them out. Right now, they will be moving to the old caves, which is beside Papa John's. Another thing that I want to kind of throw out there is we help with lead investigations. So we deal with elevated blood lead levels and confirmed blood lead levels within the county. We work closely with our state regional, Ms. Brenda Bass. She'll come down and we'll do an investigation. And we've had an increase in cases over this past year to where, and I think it's more that they decreased the level to 3.5. So if we have anybody that has 2 consecutive tests, it's 3.5 or higher, we can offer an investigation for an EBL, which is an elevated blood level. We will go there and do an investigation of the property where the child is staying and see if we can find whatever they're coming in contact with that's causing that elevation. So we've been working on that, and we finished up the year with 2 investigations last month. Other than that, I don't have any other things.
Would you like to update them on your staff and the Harley Fitness certification?
Sure. Miss Harley Linton is one of our other environmental health specialists. She was an intern. She's been with us 2 years now, September. She recently took her NEHA, which is one of the tests that we have to take to become a registered sanitarian, and she passed. So she will be another part of our team that will be a registered environmental health specialist. Yes.
So how many we got now?
We currently have 3, which is myself, Miss Harley, and Thomas June, which I introduced one Board of Health meeting. He is our intern. He's going through his training right now, and then we have a part-time, Mr. Cedric Lockwood, who focuses on our own site and will. And I cover everything else. I kind of covered animal control earlier. I didn't need any other information. Any questions? Thank you.
So the first thing I want to talk about before we start talking about the progress we've made on our strategic plan is training. I want to remind all board members that, you do your initial orientation during the first year, but also you need to have some ongoing training, out thereafter. And there is a free virtual training that's offered every other month on the fourth Monday night at 7 o'clock that you can view. The next training will be January the 27th, and I'll send out the link as soon as, the state sends it to me. The last one I sent out was on emergency preparedness. I don't know how many of y'all actually got to view it, but I did view it, and it was a really good training on what we can do as public health when it comes to emergencies.
So you can get credit even though you don't attend it live?
Right. When you register for the training and you view it, then like 2 weeks later, the state will send you a certificate. And then Christine and I will need a copy of that for accreditation purposes.
And how many of those do we need to do in a year?
There's no set number, but they do look to make sure that you are getting ongoing training while you're on the board.
So it's actually, I was trying to make sure that was the same one that I had called into a couple times last year. They are very helpful and it's really easy to log into. And so it doesn't, it's not like cumbersome or doesn't take much to kind of log on and do it, while you're doing something else too. So you can, it's something that is, you're able to kind of multitask and listen at the same time, depending on what the topic is for that. So it is.
Would it help to set a target, each one of us do 2 a year or something, or?
I mean, you can.
I mean, does it help our accreditation process?
Yes, just to make sure that everybody has it. So, I know they do it, so it's once a month,
Every other month.
every other month.
Every other month on the fourth Monday night.
I'm willing to do 2 a year, help out.
So, we can, we can say, as long as everyone who wants to do it here, so we're gonna, that way somebody would always be covered in, because it's 6, meetings out the year. So as long as we need to make sure someone from our board is present in at least every meeting. The Scotland County Board of Health has representatives on the call when they pull it, that our board is involved in the state. So, Christine, so to make that a motion as a requirement.
Yeah, I guess I'll make a motion that we make a commitment to do at least one of these trainings each year, and that our objective is at each call there would be representation from our board on that call. Second.
All those in favor? Aye. Aye. Opposed, same? Here none. That is an additional requirement added to the board members to make sure that they attend the Association of North Carolina Boards of Health free virtual training at least one a year, and that there is representation at each meeting by at least one Scotland County Board of Health.
If they can help with scheduling us, we'll probably, it'll make it easier.
Yes, I can see, I don't know how I started this,
I send the link out every time that they send it to me. I send it as a group. So I guess if y'all hit reply all, you would know
who's
who's
going, okay. So they already sent it out every month, so we can reply to who's registered for that one, we just reply all to that message.
On our strategic plan goal 1, invest in community-led solutions to advance equity. As we were talking earlier, supporting women's health grant was rolled out in October at St. Andrews. The clinic has started off kind of slow. I think we've seen 3 to 4 people in October and November. So we're still working out the glitches with the college. One of the things that we discussed yesterday in our senior management meeting was our community health worker that is out at the college promoting the program realized that we go on Wednesday afternoons, and that's the day that they have soccer games. So I think in January, we're gonna regroup and look at either Monday or Tuesday. She did a survey with the students, and that was the time that they said would benefit them better, I think, or Tuesday. So we will probably be changing the clinic days. With that being said, we have lost our provider. Her last day is December the 27th. That goes out to our mobile clinic. And well, so that only leaves one provider, and of course, she has to be in clinic inside the health department. But I am currently working on a contract with Emergence Healthcare, and they're looking for a nurse practitioner to contract with us, and one of the stipulations is that they would work at St. Andrew's Clinic. So we're working on that.
Did this grant allow us, a woman who attends RCC or UNCP to go to this family satellite clinic?
They can. I mean, it's not just for St. Andrews now. I don't know how St. Andrews would feel about having other people on campus.
You're saying,
Are you saying to work it or to
No,
go to the school?
to go to it. I mean,
Yeah.
I can imagine a woman from RCC having family planning needs as well.
But most definitely when we have our extended clinic, late night clinics, they can.
Well, no, I was actually gonna ask you about that, like about, that was on the list of things, right? It was about how can we expand it, if we know if we can reach those that are at St. Andrews, how can we replicate what we've got going at St. Andrews to other locations? I mean, just like we were talking about our 15 to 19-year-olds, but if we, I know Durham Country School is going to have some other dates or whatever at the high school, but somewhere where it could be accessible to like the teens in the community and to the other, colleges around who may not regularly have access to a health department because there's, I don't know, is there like a student health center at RCC? No, so like they don't even have somewhere to go,
We looked at all that when I was writing the plan, but you have to have an area where there's a exam. We also looked at IHA, Waverham, Siena, and different places to do satellite.
Oh, yeah.
But our mobile unit is not large enough and does not have an exam yet in there. And so we couldn't really use the mobile unit to go to the community centers with the other colleges. And if the colleges does not have space or
To make us specify why.
Right.
Well, TM2, you get full utilization of the resources you have there. I mean, I wouldn't start anything else until I was fully utilizing it. My thought was just invite those people, if St. Andrews is okay with it, to take advantage of those services. Yeah, come on campus. I mean, it's a very accessible campus. I'm not sure exactly where they hold the clinic, but, and it's not real crowded or anything. I don't know, it just might be somebody's chance to get access to care.
Going back to Eden's question, I'm trying to find somebody to work for it, is it like money to the grant that can help offset if you need to do this contract or to pay for the provider?
that's where part of the money comes from. Part of the provider that's leaving, I think, is it 20%? 20% of her salary already comes out of grant. So this contract person,
Have to cover it, okay.
part of the person's salary will come out. The hours that they work in the satellite clinic will come out of the grant. The other part would come out of in the department.
Okay, so this is me feeling like, if we couldn't find someone that would sign on to do the whole contract for the department and the clinic at St. Andrews, is there a way that we can make sure there's someone that covers just the St. Andrews portion? Because we don't want to lose the momentum that we're gaining from this because of a lack of staffing on our side.
Don't think that's gonna be a problem for the nurses, because they have a whole pool of nurse practitioners that's always looking to pick up for the 32 hours. So I don't think it's gonna be a problem. It's just, I just got the approval to reach out to the contract. Emergis, AMERGIS, is a staff, healthcare staff. And when I get to our vacancies in a minute, they're also going to put a contract on some of our nursing positions. The mobile unit, we had to suspend the mobile unit, providing outreach at the community centers due to lack of clinical staffing at this time, because before nurses down, we just have enough staff to operate our clinic. Strategic plan goal 2, promote healthy behaviors to enhance an individual's health and wellness. We're still holding the family nights on the first Monday of the month. We're still doing Milk Mondays to promote the breastfeeding. Our peer counselor is also visiting the new moms at the hospital. Her goal is to work herself up with Wednesdays and Fridays. I think right now she's just going on Wednesdays. But she's collaborating with the hospital and going in to help those new moms with breastfeeding. Flu and COVID vaccines are still available by appointment. Goal 3, ensure public health is prepared for emergency response. As I said earlier, I participated in that online training with the State Board of Health Association for the local public health and emergency preparedness on November 18. And staff has just recently completed their annual respiratory training and fitness activities. Strategic plan goal 4, continue to support promote community-wide mental health. Kathy is still participating with the county opioid collaboration. And Jana recently partnered with the Scotland Community Collaboration to host a family movie night that was funded by Trillium. Approximately 50 people were present, and the participants learned about stress management and the impact of overall mental health. Okay, goal 5, enhance recruitment efforts, employee engagement, succession planning initiatives that contribute to individual and organizational effectiveness. The employee recognition program that we rolled out this year has been going really well, and the staff are really excited about it. We're using the public health infrastructure grant for that, the $220,000 that we got. And we started that July 1st. So the employee of the month is nominated, they're nominated by their peers, and then it's voted on by senior management from the nominations. And the person that's chosen receives a $50 award in their paycheck. Well, we started noticing that we were getting some nominations for senior management. So we divided that up, and we have employee of the month, and we have a senior management employee of the month as well. And the names from July to December, the winners of the employee of the month, put them in the hat for employee of the year. And so at our staff development day in December, senior management had voted on the ones that were nominated July through December and chosen employee of the year out of those. And that was Ms. Jordan Locklear, and she received $100 in her paycheck for employee of the year. And the senior management team member of the year happened to be Mr. Tim Hartley. He also received $100. So it's been a small morale booster, but we're getting there. but I think they all have enjoyed that particular employee recognition program that we rolled out in July. However, we do have a lot of vacancies. The nutritionist too, this position has been posted for over a year. It's currently being filled by Nutrition Plus, which is contract staff. It's frozen as far as not being able to be hired as a county employee. But we are able to contract 3 days a week for nutrition. County managers. Week director nutritionist, our week director just left. She decided to take a job where she could work from home. It became vacant on November 22nd. I sent a request to post that position, and when these were sent out, it hadn't been posted yet, but it is posted now, and it will be posted until January 10th, so we're hoping to get some qualified applicants for that. It can be a nutritionist, or it can be an RN for that position. And I also sent it to the state listserv for the state WIC consultant to send it out from the state listserv. Public health nurse, that says 2, but it should say 3. They usually start as a 2 and then work 2 and 3, what we'll work against. That's the enhanced role nurse for communicable disease. We have 2 positions vacant. One position has been vacant since April of 2023, which Donna has been filling in on that position. And one has became vacant November 1st. So we are searching for qualified candidates to fill these positions.
3 of those frozen.
No. Public health nurse 1, we had one that became vacant May the 3rd of 24, and one that became vacant in October. Both of these positions have been advertised. They were advertised for 30 days. We only have one person to even apply, and Donna and I will be interviewing that person tomorrow to see if they're going to be a qualified candidate or not for one of those positions. The other position, we're also interviewing 3 people that Emergis has sent us, and we will contract with one, and one will be hired as a county employee in She.
Can you discuss why those 2 positions are keep away? In general, just the reasons.
Income, salary.
Salary, that's what I thought. You know, it's really hard to bring new people in and train them because, you know, it costs a lot to hire a new employee and it costs a lot to train. And, you know, if the salaries just aren't there, people just aren't going to stay. It's always been a problem.
And we're hoping this contract person that Emergis is sending, the contract is for 6 months, with the end goal being that they will be fully trained in all areas of the clinic and would want to go full-time with the clinic. But as I said, we haven't had but one person apply and it was advertised for 30 days. But like Donna said, I think it's out.
So when we get those people through Emergis, does Emergis pay them more than what we will pay them when we hire them full-time? Or do they pay them the equivalent of what their salary would be per us? Okay, so we're ultimately contracting people to come and work where they're getting paid more, that when we offer them a full-time job, they're going to make less.
Is that more though 1099, or is it more with benefits?
It's more in their check, because I asked the question on the interview, I wondered what her hourly rate was that she's saying that she was paid.
So the
And she
difference in
told us-
burden is substantial.
Yes,
right?
she told us that Emergis, in her interview, she volunteered, was paying her $35 an hour. If you take the county, what they start out with, and you divide it by an hour, I think you give it $24 an hour, so you give 24 and 35. So
We're hoping to take an $11 hour pay cut. So
Because they were,
Well, but I think there's a, to be fair, you have 24% for on top of pay. So you really can't compare it without other benefits.
But she is, Emergis does offer benefits.
I would say whenever you do the 1099, especially for medical,
1099 means no benefits.
well, not
You're
just 1099,
responsible.
but for the other, the way that Emergis is doing theirs for here, like I know for my 1099, yes, mine is my full. I don't get benefits because I get my benefits from my full-time employer. But this is their full-time employer, so like with the traveling nurses and some of the other ones, they offer them those things as a perk, so that it does include like their health insurance and other things, so that those things are included, and that's not like additional from that 35. So like they're getting paid 35, and yes, they may not be getting like 401ks or short-term like add-on like benefits, like those things that are, yeah, like they may not be getting those things, but I'll even tell you from my nurses in my clinic, when you're dealing in healthcare, the environment that you're going into and the things you're dealing with every day, you may love what you're doing, and yes, it may be like, oh yeah, I'm getting these really great benefits, but if it does not correlate into something that they're gonna take home, like to help them feed their kids or pay their bills, we even have we have nurses who leave our clinic, and our clinic, I mean, we offer some amazing benefits, and they leave solely because that hourly thing, like, and I mean, they're not getting paid a lot, they're $20 an hour is good for them, so that's on like 24 for me. Hearing that is still decent, but in the environment that we're in now in healthcare, 24 is not going to get us to retain quality. You can get people, but I'm not sure if we're gonna get the quality that we want, and if what would be long-term, would we wanna keep that position as a contract, like Ameris always just keep somebody contracted with them, and therefore it doesn't have to come back on us trying to find somebody? Like, is that a possibility? Because if they're gonna pay him the 35,
And I mean, to learn public health, because I don't think he's not given us anyone who works public health. For a public health nurse to learn public health, just skim the top of the iceberg, is a 6-month window. If it's a really smart nurse who learns quickly, 3 to 4 months, she can be in the clinic, because these positions we're looking at is actually to function just to try to get our clinics to continue to run and get the patient numbers up. I'll still continue to do communicable disease, because this is a very specialized role that we can't spend that money to send them to school to learn to be a communicable disease while they're a contractor. It doesn't make any sense. And as far as the nurses who left, I know that salary was a thing, but when you take away pay increases annually that we were getting from, I mean, why are we even doing an annual evaluation anymore when there's no reason to do it? You don't get a raise, they took that from us. We don't get a lot of stuff now, so there's really no hope for any salary increase at this point. Yeah, I mean, and the benefits are not that great anymore, so. Yeah, I
Is
mean,
there any possibility of looking at some of the RNs who have left or retired in the past and seeing if they would want to work a day or two a week just to, because most of the time, if you've had this education, you want to kind of, you do want to stay sharp, and you want to be, as we age, if you've got you can have a 65, 60, 68-year-old nurse who is a young 68 versus an old 68 who is not engaged in anything. So sometimes people want to keep their brain working, and they might want to work a day or two a week, or even 2 days a month would be better than nothing. The RNs who were here were excellent, and they knew their job. I mean, they were absolutely excellent. I knew most of them and worked with a lot of them. They're excellent. They were excellent. They're,
I would offer to, perhaps we should look at what the other 100 counties are doing. I mean, we're not the only one in healthcare, we're not the only one that's competing for this talent, and the pay structure is very similar all over the state, I assume. So, except in your biggest metropolitan areas. So, we ought to look at what others are doing, because I like the idea, finding people who are previously retired, or, I mean, I know nurses who have left and
There's
gone to teaching,
Yeah.
and,
Did you
stuff
know
like that.
that Judy came back during COVID, remember? Did she come back during COVID for a short time? Wasn't she, somebody came back?
Tina did for a little bit. Debbie left, she was a community disease TV nurse. She doesn't even have a license anymore. She's done. Judy is too, she's just not, she was an immunization nurse, but she's not. She's got other things going on. There's just not any of them that are out there anymore.
I will say that Donna and I reached out to the nurse that left on October 18th, and she's completed her orientation at the hospital she's working at. And we worked with the county manager, and she agreed for this too. That nurse is gonna come back and work 3 days a week because part-time. So we are getting her back too.
And the job that she was our community disease STD nurse too. The Hope County had a similar job, doing less than what she was doing at our health department for $20,000 more. That's Hope County, Hope County.
They were paying more. It doesn't make sense that we cannot keep the positions we have. I mean, it's hard to compete with the hospital really, but if you're a registered nurse, if you're a person you get back to school to be a registered nurse, you're counting on a good salary and helping support your family. And you're gonna take the highest paying job you can get, because that's a lot of education right there.
So can you, actually, can you look at the positions that we have open, those that may come open in the next year? And you kind of know what we're paying hours, right? What a mayor's will contract for those same positions, and what's the state average for that position? Anything, just a couple. And for the counties surrounding us, like the counties that touch us, because the ones that touch us,
That's already been done.
Yeah,
Getting
can you-
data and going and sending it to you, because
Yeah.
it was done in the recent salary study that the county, had done. And they looked at Hope County, Richmond County, Robinson County, they looked at all the surrounding.
Moore County. Did they go?
And Moore County,
Is there
they
any
even
other
went across
touch?
the line and looked at Marlboro County. in the
Just
salary
off the
study.
top of
So
our
I
head,
think
is
that's
there
very.
a substantial difference from county to county?
And you said.
So I want you to
something
pick
about
it for the ones that we have open. Because I mean, if we got people in there and there, I don't, right now, I want to focus on the ones that we've had open for over a year and still can fill. And those that are positions that are pivotal in us operating and doing what we're supposed to do.
I can tell you too, when you use contract companies like that, normally there's a huge price you gotta pay if they try to convert your employees. So they keep you on the contract. So it doesn't really help you solve the problem in the long run. It helps you in the short run, but I agree with Dr. Singletary, you gotta have a strategy for what's next, because you can't afford to do this contract. You just can't. Even the hospital, most of the travelers are gone. They have travelers in very limited areas because of the financial impact.
You mentioned Monica reaching out to the other counties. I have reached out to other counties, and Cumberland, Hope, and Moore are currently using this contract company. That's how I got emergency information. Because they're in this the same situation we are.
I wonder too if sometimes people are using LPNs or paramedics in certain roles. I know the hospital has opened up some opportunities for people with those skills. That may be an opportunity, and I don't know that someone else in the state isn't doing it, but that may be a question worth asking. Because in this environment, people are thinking outside the box and they're trying things, you know, within safe limits, of course.
Ron, would you like to speak on that?
No, in the past, Scotland County Health Department has utilized a couple of LPNs. And we've thought about MOAs, but in public health, it comes along legalities. LPNs are very limited to what they can do versus an RN. I mean, even so much as interviewing a patient, there's certain things they can't do. So you're limited in being able to, your provision of care because they can't function at the level an RN can. I mean, right now, public health, they want their nurses to have a BSN. And they're also wanting them to be a certified public health nurse. So there was always a public health nurse course they had to take. Because they were not, didn't have a 4-year degree. Now, it's turned over to being a certified public health nurse. And they want everybody, even RNs or BSNs, to do ADNs to do it. So it's complicated to have LPNs and
I
public
think it's a
health.
question worth asking.
I can ask my nurse consultant.
The world is changing in a lot of ways, and
We've asked it as recently as last year, so.
Is that a state?
What's the state requirement? So I think some of it is that the state.
sure, some of it, no doubt.
So I think some of these are that the state mandates it has to be an RN and here in line is where the issue is for all the surrounding counties.
We have
Every medical specialty is fighting for the same RNs coming from this RN program around.
And we already discussed it, the advanced providers, they've been under 27. More questions?
So limit on that salary, limit on the salary for those employees, is it, part of that, I can't remember what we call it, part of that STEP program where you come in, you know, is it capped by the state? Because it's in a, what is it called? It's in a, it's not a state. So is it capped by the state? Is there a minimum recommendation, and then is it capped by the, it's capped by the state? So you can't pay your registered nurse more than $25
That
an hour?
step or level.
That's the start rate.
So you can't,
So then that's the problem.
Not necessarily, the range is pretty good. One, I'll tell you, I can identify a problem up front. So, say I've been a nurse for 31 years. If I leave here, well, I won't use myself because I have public health experience. A nurse who's been a hospital nurse for 15 years wants a job in the health department. They do not get credit for their nursing experience when they come to public health. They either have to, and they've actually expanded what you could have credit toward your public health nursing. If you work hospice, if you've been a school health nurse. Used to it was you were a public health nurse or you were a school health nurse, that's the only way you got any of your nursing years of experience applied to your job and how you were salaried in. And so it's tough.
Well, who makes those decisions?
The state.
Okay, so it's out of our control. So, but who also accredits us?
The state.
And if we don't do what they say and we lose our accreditation, then we lose our funding. And we can't afford that.
But I think there's not anybody who wouldn't say to the state, we need to pay them. Right? Nobody would be reluctant to say that. It's just whether or not the state would update the guideline to reflected.
Alright. And so, that concludes our report. Any other questions? Alright. Any old business? I think we kind of talked about all the stuff like I'm going to, make sure we had all the things that we kind of had put in place from the last year that we were either talking about or wanted to do. We had COVID funds that we had to, find to get into stuff that we have in those packets, and I think it was somewhere listed how many we made and the churches came and picked them up. The mobile unit that started to go out now, which shows our increase in like our exams and our immunizations. We started the FP pregnancy clinic at St. Andrews. Clearly every meeting we were looking on ways to increase our expenditures, increase revenue, and get more people in and through our health department. Our intermortality grant that started, with our Milk Mondays, which I think got us, like saying, with some award, right? And the Improving Families, which has started with our infant mortality with the parenting class. We now offering paternity testing and drug screening for our DSS cases, and we have partnered with our DSS to start making sure that we're going to have like a foster child clinic, so that all of the foster children in Putnam County get their required exams and things through the health department, because that is the area where they have to get it. We, get reimbursed for those things, and why are we not getting reimbursed for services we're supposed to be doing anyway? So, we started the foster child clinic, so you'll see that new line item like on our list of numbers, because that's something that we, just partnered to start to do. And oh yeah, one of the big things is we got animal control, we helped identify where we were. That was one of our decreasing expenditures and increasing revenue, because we were spending a lot but not getting much from it. So that was one of our big ones for the year. And now we will go on to new business, which will be nominating an election of new officers. I think Ian was over nominating this year, right? All right, I'm gonna go.
So the nominating committee, nominated Dr. Barry Hughes for vice chair. And with no participation of myself, they nominated me for chair.
All right. So, do we have any opposing running? No. All right. So, for 2025, 2026, Mr. Ian Jenkins will be our new Board of Health Chair. And Dr. Bear Hughes will be our new Vice Chair. Ian knows this is a smile of joy. All right, so we thank y'all, and so I finish up, you know, let you
No, he would take over the big
I was, you see, I was like, oh, Derek has to be fast.
So start after January 1.
So after January 1, we will be led by our wonderful Ian. Okay. This is actually like that, like trust of passing the torch, because we both grew in this together.
Yeah.
So it's like only fitting that Ian comes up next. I think we might agree that like 1 year is about all the chair can do here. So I'm just,
Looking forward to it.
yeah, I'm proud of you. All right. All right, and we do need to approve our 2025 Board of Health schedule that was included in your packet. Notice that our meetings are every other month, so we will have a meeting in February, April, June, August, October, and December. Do you have any discussion or need to change any dates of our meetings? Here, I get a motion to accept these as the official board of health meetings for 2025.
Second.
All right, then moving in second. All those in favor of having these as our 2025 board of health meetings, will say aye.
Aye.
Opposed, say. You're done. Okay. So you may put these in your calendar as our approved 2025 board of health meeting. And then we will move on, we do have a new fee schedule for vaccines that Ken is gonna review. I think he put them out on your desk. This way.
I'll be really brief. Just to really say that we have a multidisciplinary committee inside the health department that reviews fees. Policy says we review these fees, we take the cost. These are the private immunizations that we talked about earlier. We take the cost of those fees, times it by 5%, and then round it up to the nearest dollar. So we do make some offset to the cost as well. What you'll see in the very far corner, the very last column is proposed fees, and you'll see 23, 24, and 24, 25. And this is actually what we're just asking to be approved by the board. What's in that last column? Any questions?
I make a motion to approve as is.
All right, then moving in second, all those in favor of accepting the vaccine schedule as presented, say aye.
Aye.
Any opposed? It's been approved, we will accept these as our schedule.
Thank you.
All right. We now will be entering closed session to consider the qualifications, competence, performance, character, fitness, conditions of appointment, or employee or prospective public officer or employee per general statute 143-318-1182. All those in favor, adjourn.
Should we do our round of one? I guess. Board member.
Oh, they think it's her, next time.
I talked to Dr. Bowling. I know we were looking for an optometrist member for the board. And there was some discussion that maybe he would come back or something like that after a break. I talked to him Sunday and he said, no, I'm not coming back. He said, however, if there's an issue that comes up that involves eye care, he said, I'm happy to help on a one-off basis to help with that as needed. But he said he would not be coming back. So as I read the bylaws, we have three options to either replace an optometrist here, get one from a neighboring county who may be willing to serve, or appoint a civilian member in that person's place. As a commissioner, one of my personal commitments is that we fill our board positions with people who have a desire to serve and have something to contribute. So I'd like to recommend that I asked him if there was another local optometrist that could fill in, and he said no. I don't know that you're going to get someone to drive from a neighboring county. If someone does know of somebody, that would be good as well. But I think finding a citizen who is interested in serving can also be helpful, especially knowing that Dr. Bowling would be available on a case-by-case basis, when there's a real need for that.
Okay. So, yeah, I think that's really fine, the way we really have operator was like, if you know someone that can fill our open seat, then we want you to invite them, and, Ms. Christine will send them the link to fill out the application so that they can come on to fill it. It's the same thing we're doing right now also with Ian, who has someone who knows that can fill our pharmacist seat. And we've been trying to figure out about the veterinarian seat also.
So do we need to can I put forward a motion to have a community person appointed in that role so that we have it documented as to why we did that? It just seems appropriate. To do that.
Especially because you did the legwork to find there's no other optometrist in the
Yeah.
county. I mean,
No.
it doesn't seem like we have another
Yeah.
option there.
So if we could open that up, then I'll feel good about advertising it, and because I think we ought to cast a broad net for someone talented, motivated, who wants to serve.
Sure.
So we were talking about a pharmacist though. Do you have a pharmacist that you know that wants to?
Yes.
Yeah.
Okay.
And I forwarded her the application link for online to submit her application.
And so that was one thing, like for last year, like me and Ian, like really, were working on trying to make sure we could fill those seats and trying to find, like, make sure we exhausted all efforts to find the, like, official person who should be there, so that we know that when we say that we don't have anyone, that we've like tapped every angle and we're not overlooking someone who may
Yeah, the
want
pharmacy
to
seat-
serve.
In the pharmacy seat, we have just now.
Just now
had
vacated. Yeah,
yeah.
that was Mr. Todd.
And the veterinarian
Veterinary.
seat has been vacant for
March.
about 9 months.
Was
Yes.
it March?
She was our
or
second meeting. So it would have been April would have been the last.
April? So that was Dr. Johnson.
Yeah.
And she actually tried to find someone to take her spot when she left. So there may be like 2 community people that may come, because we have not been able to find a
I
veterinarian.
looked up since our last meeting, asked around again to see if anybody's moved, if anybody knows about.
Yeah, and I just started in, a kind of a relationship with some of the veterinarians at the Rayford Animal Hospital there. And so,
We also have a public member vacancy that is, similar that position is
So I'd like to make a motion that for the optometrist position, given Dr. Bowley's, he's served for 6 years and will not continue, that we appoint a public member, or we open it up for a public member to fill that seat.
Second.
alright, although that they are opening up our optometrist position for a public member, say aye. Opposed? Hear none? Here, we will just open that one up.
Just for clarity, can you bullet point the ones that are open?
So
We
the
just
ones
talked
that,
about
yes,
before.
so and note, Ms. Christine, that our open positions are our veterinarian position, our optometrist position, and our community member position, and pharmacist. We do have one potential candidate for a pharmacist position. We'll advertise for the optometrist now in the community. And then we have an additional community one. And we got,
Veterinary is over.
yeah,